Dr. Duncan Reid. Sorry about that. By Dr. Duncan Reid. Dr. Reid is a clinical assistant professor in the Department of Medicine at the University of Washington. He is the director of the Ethnomed website, and his clinical practice is as a general internist in the International Medicine Clinic at Harborview, where he provides care for adult refugee and immigrant patients. And he's going to talk to us about TB care in the Marshallese population. Take it away, Duncan. And Duncan asked me to interrupt his talk with questions in the chat. So if you have questions, please put them in the chat, and we'll either pause during the discussion to discuss them or wait till the end. And then last thing before Duncan gets started, you see that Catherine put the link to Ethnomed in the chat if you're interested.
Okay. Thanks so much, Bijan. Can everyone hear me okay? Okay, so yeah, I agree with what Bijan said. I am a primary care physician, so not a specialist in TB by any stretch. And appreciate your time. I think any feedback that you have for me, during the talk or at the end of the talk, I think is really, I think would be very helpful for me. So let's see if I can share this. Uh-oh. Can you see this screen?
Yeah, it looks good.
It looks okay. Okay. So this is a community TB profile project, a Marshallese community profile. So no conflict of interest that I am aware of. And then the objectives which we disseminated is demonstrate the importance of cultural and historical context to providing patient-centered medical care, describe barriers to TB diagnosis and treatment among the Marshallese community, and provide culturally informed resources to providers who are treating patients from the Marshallese community to support culturally appropriate TB care. So I'm here at International Medicine Clinic at Harborview Medical Center, and we take care of a lot of patients from different countries. So I've been trying to engage residents more, and I'll often start off. So when I talk to residents in the hospital about cultural care, I use this basic case, based on my own experience, and I've simplified it here. So here's a 60-year-old man with kidney disease, and he recently developed a productive cough and weight loss. And I asked him, he arrived in the Marshall Islands about 1 month ago, previously had not been established with medical care. He explains that he is hopeful to leave the hospital as soon as possible, and he seems to be distrustful of providers. So I asked these residents, what do you know about the Marshallese community, and how could that knowledge inform your care? Typically what people say is, I took care of this Marshallese patient once, and they were pretty sick. They usually had some renal disease or something. And I asked them, what else do you know about it? And you're like, well, not much. Did you use an interpreter? And they're like, well, it was pretty hard to get an interpreter. So I tried to use some cultural touchstone for them, and I introduced this character. Are you guys familiar with this at all? So this is SpongeBob SquarePants, and I think really big in the 90s, maybe the early 2000s. Does anyone know where SpongeBob SquarePants lives? And this is how I introduce it to these residents. Feel free to shout out.
He lives in a pineapple under the sea.
You're right, and there's a pineapple, and there's the sea, right? And then if we think a little bit more, we're like, oh, it's Bikini Bottom, right? Does that sound familiar? And then the question is, did you know that Bikini Bottom is a real place? And there it is. So if you look on this map, we have the Pacific Ocean, there's Hawaii, there's Papua New Guinea, and that red dot on Google Maps is Bikini Bottom. Let's zoom in a little bit more and see if we can see where it is. Oh, we have the Marshall Islands, or archipelago. And then if we zoom in on this right side here, at the very top, we see this coral atoll, and that's Bikini Bottom. Its actual name is Bikini Atoll, and it's a fossilized coral reef that forms like these beautiful structures. There's a nice bay in the middle. Do you see where this arrow is pointing? Do you see this little deformity on the reef? Does anyone know where this is from? I'm sure some of you know exactly what it's from. Does anyone want to posit a guess? Feel free to shout out.
Jason Simmons in the
Bomb.
comments, but bomb.
Bomb. Yeah.
And
Hydrogen bomb.
Yeah, it's a very edgy answer, but it's the correct one. So at the end of World War II, we dropped 2 nuclear bombs on Japan, one on Hiroshima and one on Nagasaki. After World War II ended, we designed a bomb that was 1,000 times more powerful than either of these bombs. And we looked across the Pacific and said, you know, where can we test this thing? So we found this island. There are people living on it, so we moved them off, and then we blew it up. This bomb was 1,000 times bigger than the atom bombs that we had used in the past. It was miscalculated, so it was twice as strong as they thought it was going to be. It hit a passing Japanese fishing vessel and exposed everyone to fallout, but more importantly, exposed the whole island archipelago to nuclear fallout. As I mentioned, these inhabitants were forcibly relocated to another atoll where they promptly started starving, so we moved them again. The incredible thing is it's at least 23 nuclear tests, probably more, were conducted until 1958, all above ground, something that's not even done worldwide right now. And here is an image of Castle Bravo, the first in a series of high-yield thermonuclear weapons, a 15 megaton yield. So what I point out to the residents, I said, you know, in about 3 minutes, I can tell you some things that I think are probably essential to understanding the Marshallese population. And I feel like every population has a similar story, maybe not as traumatic, maybe not as vivid, but something equally important for you to understand how to deliver care to their population. And by the way, so why is SpongeBob a talking sponge? Oh, it's because he was irradiated, right? So there's this dark humor behind one of the most iconic cartoon images of the 90s and early 2000s, which is embedded in this story. And I just use that as a hook because these kids are, you know, kids of the 90s and 2000s. So it's just giving them something that they can latch onto. This brings us to the topic of TB in the Marshall Islands. So the Marshall Islands is a high TB burden country, estimated incidence of about 500 cases per 100,000 population. So that's over 200 times higher than in the US. You've been to Manhattan, right? Or you've seen photos of Manhattan. 2 of these islands, one of them is more densely populated than Manhattan. The other one is almost as highly populated than Manhattan. And one of the thoughts is with this extremely high population density, TB has a greater foothold and there's greater transmission. In 2010, there was a public health emergency declared due to the sudden rise in multi-drug resistant tuberculosis. And the WHO began mass screening in 2017 and 18 for both latent and active TB with the goal of TB eradication. So again, I come back to this. I say, you know, in these 3 or 4 minutes, we learned enough about the Marshallese population, probably to have more empathy when we encounter them, and to realize that there's a legacy of power dynamics and possibly distrust that plays a big role. And I would posit to them that a cultural and historical context is essential to providing patient-centered medical care. And this can inform the provider, you know, what diseases should be considered, right? TB needs to be in the front of your mind when interacting with this population. And then we can also discuss how best to approach diagnosis and care. And we'll get into that. So tuberculosis in King County, Washington. So King County is the most populous county in Washington state. It's the home of the bustling metropolis of Seattle. In 2022, there were 111 cases of active TB reported in King County, representing an incidence of about 5 cases per 100,000 people, or about double what it is nationally. Of these 111 cases, 86% occurred in people who were born outside the US. We look at this pie chart from 2022 of where people were born who were diagnosed with active TB. 38% were born in other countries, which is not that helpful. But we have Vietnam, India, Ethiopia, Philippines, Mexico, China represented prominently on this. And USA, so domestically born people, account for about 14%. So why did we start off with these Marshallese? Well, in Washington state in 2023, over 12% of all active TB cases were represented by the Marshallese community. So this is demographically identified as Marshallese. So it could be country of birth, race, ethnicity, language, country of usual residence, but it's still pretty profound. So out of 111 cases, over 12% were represented by Marshallese. people. In the 2010 census, there's only 22,000 Marshallese in the US total, and just over 2,000 in Washington state. I didn't see any current numbers, but my guess is maybe 3,000, maybe 4,000 Marshallese, but they're accounting for a very high proportion of TB infections, or TB disease. And it's in the news. We see it in the news. These are news headlines just obtained in the past year. You know, Kentridge High, you do all this contact screening. Tacoma warned of active TB case. Tacoma's just south of Seattle. There was talk of seeking a court order after a patient declines medications. TB outbreak in the state prison system. And then tuberculosis case in Auburn School District, which is just south and which is the hub of the Marshallese community in King County, prompts evaluation. So it's really in the news and people are thinking about it. This brings us to the TB Cultural Profile Project, and this represents a collaboration among three entities. One is King County Public Health TB Program. Second is Ethnomed, ethnomed.org, which is part of Harborview Medical Center, and HealthPoint Clinics. So the King County Public Health TB Program has really been central to this effort. They have a very novel community navigator program, which began in about 2019 in the setting of COVID. And there are community representatives that represent over a dozen communities impacted by tuberculosis, and they participate in regular community engagement and education. Ethnomed I talked about a little bit, which is this web resource, which is really focused on cross-cultural medicine, and we do a lot of our independent projects and independent research. HealthPoint Clinics is a primary care system which serves a large immigrant population in King County. So we do have some TB cultural profiles on Ethnomed, but they're a few decades old. Here is just some examples of what they look like and the contents, you know, causes of TB, symptoms and progression, treatment beliefs. So it's really based on interviews with the community. So there's a collaboration with King County Public Health, as I mentioned, and they have community representatives that are on contract that represent these 16 different communities, which I think is just unparalleled access. So of these, we've already completed TB interviews for the Marshallese, Ukrainian, Kenyan, Congolese, Iraqi, Ethiopian, and Afghani communities, really asking them, what do they know about, what is their understanding about TB? What is their experience in the community? What have they heard in the community about accessing TB care? So based on these interviews, there's some take-home points, well, from the Marshallese community and from communities at large. So in terms of clinical symptoms, testing and treatment, you know, there's this general awareness of coughing and weight loss as symptoms of TB. So pretty much everyone has a sense that that's true. There's less awareness of extrapulmonary TB. However, across a lot of these groups that we've been interviewing, there's confusion regarding, you know, the difference between active TB disease and latent TB infection. So most communities are not even aware of what latent TB infection is. And even the Marshallese, where latent TB infection was being actively treated, they really weren't sure of the distinction between TB disease and LTBI. Diagnostic methods, a lot of people are familiar with the Mantoux testing, these skin tests, but the idea of these interferon gamma release assays or quantiferon, most people didn't know that there was a blood testing option. There was also a lot of confusion over the role of a chest x-ray. People were like, you know, I tested positive on the skin test, but they did the chest x-ray and they proved that I don't have TB infection. And then treatment options for latent TB and active TB, there were just poor understanding what the options were, that there are different regimens. And even people in the Marshallese community that were treated for TB were not sure if they were treated for active disease or for latent TB infection. And there was also questions of what degree of protection the BCG vaccination provides. This was only recently introduced in 2004 in the Marshall Islands, so really not as pertinent. So some more specific take-home points from the Marshallese community. There were some prior outreach efforts where there was actually targeted screening being done at community events with the Marshallese community. And because of this, we had some difficulty finding people to interview. They were saying, you know, didn't we already give you your answer? Didn't we already participate in this outreach? They also mentioned some unique social factors in the Marshall Islands. So think again, there's 2 islands that are nearly as densely populated or as densely populated as Manhattan. So there's really little privacy in the Marshall Islands. And they said it's widely known who is being treated. You could just look next door, you'd see public health coming by, and you're like, oh, they have TB. They also pointed out social culture. They said, you know, the Marshallese culture is so social. One respondent stated that, you know, she knows that she needs to isolate from someone with TB disease, but she said, you know, if they're a really close family member, you know, it's a really good friend, you really couldn't do so. Wouldn't be socially appropriate, so you wouldn't be able to isolate. They also said there's stigma surrounding diagnosis of both active TB and latent TBI. And they said, you know, people wouldn't really know which one you had, so they would try to avoid you if they could. There was understanding that the disease is treatable, and stigma often ended with the completion of treatment. It really helped that you could see your neighbors getting treated and you'd get to see their DOT every day. So there's a really unique situation with the testing and treatment in the Marshall Islands. So there's this recent WHO campaign to screen and treat all individuals for active and latent TB. So this is really unusual because most other countries don't even treat or screen for latent TB infection. The confounding factor here was that WHO enforced a directly observed therapy for both active and latent TB. So because of this caused a lot of confusion about who had active TB and who had latent TB infection. So the assumption from our informants was that most people that you see getting treated, they had TB, and you would think that's TB disease. One benefit of this WHO campaign is that testing and treatment was normalized. You know, people said it's really difficult to evade testing. You know, the public health is everywhere. Public teams would come to your house. So it was much easier just to get tested than to avoid it. This brings us to the US, and they experienced a lot more barriers to getting tested and treated in the US. So there was a reluctance of patients to discuss TB with new providers. However, due to limited insurance coverage, limited access to care, community members are often receiving a new diagnosis of TB disease or LTBI when they're establishing care. And they said, you know, this is this really shocking diagnosis, and it's with this doctor that we don't even know about. We don't know them. We don't have an established relationship with them. They mentioned that travel is a common barrier. They said, you know, often we only have one car per extended household. It's really difficult to go pick up medications, going to follow-up clinic appointments. Furthermore, Seattle has become so prohibitively expensive for housing that a lot of these immigrant communities, the Marshallese in particular, are living quite a ways away, maybe a 45-minute drive away from city center. They also endorsed a preference for translators who are the same gender as the patient, but they noticed that this was very difficult because there's a shortage of translators. In Washington State, there's a shortage of the whole program of getting translators certified across languages. So there's a shortage of Marshallese translators in particular. And they said, you know, if it's male and female translator and patient, they're really less likely to divulge information. They also mentioned that there's increased privacy in the US. They said, you know, back in the Marshall Islands, you really would have to get treated if people were seeing you getting treated. But here, you know, you're far away, you commute, you're not seeing a lot of people. So the social pressure of getting tested and treated is really not present. So people feel like, you know, they have greater confidentiality. They really can decide not to get treated. And there was reluctance to participate in public screening events due to stigma, you know, and there was this concern, which is very real, that any results could jeopardize employment. A lot of immigrants, particularly in the Marshallese community, work in childcare or in medical jobs where getting a positive latent TB diagnosis, you'd have to get proof of treatment. People in the community also shared information a lot, so there were common complaints of side effects from latent TB treatment. So a high proportion of patients do not complete the course. We interviewed some translators in the community who estimated, they said, you know, only about 1/3 of people who started a treatment course would actually complete it. People that had side effects would share it with others. So people who had never even been screened for TB or treated would be aware of the side effects, and that would be one of their first concerns. Other relevant history, so this nuclear history that I started off with, respondents were open about this history and wanted it more widely shared. They said, this is really the basis of the legacy of distrust. I talked to them about SpongeBob. I said, do you know where he's from? And they're like, of course he's from the Marshall Islands. And I said, is it okay to start off with this? And they said, yeah, that's fine. There's also this history of a compact of free association with the US. So the US provides economic and financial aid in exchange for exclusive access to land and waterways for strategic purposes. So the Marshallese are not citizens or nationals of the US, but they have this special agreement where they're entitled to apply for admission to the US as non-immigrants without visas. So Medicaid access to them was cut in the 1990s and only recently reinstated in 2020. So it was another big reason that a lot of these Marshallese people were not getting medical care. I asked them about other health concerns, and they said, diabetes is a big concern in our community. There's a lot of barriers to care. They often present late, often with renal complications. They also mentioned poor diet. They said it's established in the islands. They said produce, any fresh vegetables, fresh food is prohibitively expensive back in the islands. So people aren't eating much of it, and they come to Seattle and they're just not used to eating it. So just to start off with some recommendations, so this is going to be at the top of our profile. We recommend TB screening for all individuals from the Marshall Islands. Consider screening for US-born members of the Marshallese community. We recommend highlighting the impact of screening on community health, particularly that of children in the community. We recommend explaining the difference between latent tuberculosis infection and active tuberculosis disease, with the expectation that people don't know this distinction and might not understand it even on the first explanation. We recommend close follow-up in clinic once treatment has been initiated to ensure continued compliance with regimen. Anecdotal reports that only 1/3 of people who are started on regimens complete them, and then recommend use of in-person Marshallese interpreter when available with gender matched to that of the patient. Here are the profile sections. I won't go into detail, but each of these profiles is going to be standardized across all of these things. And we have disclaimers, and we're very cognizant that with the limited number of interviews that we do, typically around 6 community members, that we're only getting a small piece of a small perspective, and it's not necessarily representative of the entire community. So far we have 3 TB profiles currently in draft form. The Marshallese profile is currently undergoing final review and will be up shortly, hopefully in the next month or so. We have community interviews continuing for the remaining community groups, and I think we have 7 community groups completed so far. The other thing that came up was it was very challenging to get good recordings. So I was recording, like trying to listen, trying to review the interviews, and there was a lot of background noise. So then I said, why don't we just get some really good recording equipment? So we have separate channels on some professional podcasting equipment. And I have a current collaboration with Raj Sundar. He's the founder of the healthcare podcast, Healthcare for Humans, where we're publishing interview excerpts, some interviews with some of the community mediators, and developing episodes focused on tuberculosis in various communities and some of these challenges. We also have a plan to produce TB campaign materials. So we have a professional photographer on staff, and she's been attending community events and taking photos with consent forms to be used in community level TB information campaigns. A lot of communities were saying, right, these generic information forms are not as helpful. We really want to see people that look like us on any distributed material, addressing concerns that are specific to our communities. Some additional take-home points. I talked about the ones in the Marshallese community. In the Iraqi community, many interviewees said, the BCG vaccine is protective against infection. They're like, we got this. We don't have to worry about TB. In the Congolese community, TB is closely associated with HIV. So I talked to some people and they said, well, if you want to talk to me about TB, you're really talking to me about HIV. And he's like, look at my life. I have enough problems right now. I don't want to have to deal with either of these. They also pointed out that there's a difference in understanding about TB between rural and urban populations, which is across all of communities that we saw. In the Ukrainian community, interviewees stated that they were familiar with doctors giving orders rather than options. So when I said things like, I recommend, they're like, oh, if it's a recommendation, I guess I won't do it. They also mention a legacy of distrust from Soviet-era medicine, including vaccination hesitancy. More recently, on interviews with the Kenyan community, I was really struck that there were two cases that everyone talked about. And one was a woman who died from complications of INH, and another one, a woman who received INH treatment for latent TB and ended up requiring a liver transplant. I think the very striking thing is that everyone knew about it. I don't know any details about it. I haven't reviewed their medical records, but I guess that's not the point. The point is everyone knows about it. And when I asked people, will you get treated for latent TB? They said, absolutely not. We know about so-and-so and so-and-so. And because of that, so I interviewed a reverend, I interviewed a nurse, and they all said the same thing. They said, we recommend against treatment because of these two cases. So really an uphill battle. But I think the interesting thing is that these issues are hyper-local and very community focused. So it's not even a Kenyan community issue. It's a Kenyan community in King County that knows these people. More acknowledgements than I can really imagine. Funding from the Tuberculosis Elimination Alliance. I really want to highlight our public health colleagues, Katie Budd in particular, Caitlin Gardner-Torin for just incredible work in pushing this forward. Frankie Era is in charge of all of these community navigators. He's allowed us to get just